for delay. It's a pleasure on behalf of the Egyptian Society of Radiology and Nuclear Medicine and for myself to join my colleagues from many countries and specialists. Our topic today is pediatric chest clinical imaging guidelines and common findings. Outline of the lecture: chest imaging modalities and techniques, clinical imaging guidelines and radiation safety, inappropriate referral, common patterns, and common findings. Clinical imaging modalities are X-ray, whether conventional, CR or DR, ultrasounds, computed tomography, magnetic resonance imaging, nuclear medicine, hybrid imaging, and imaging-guided intervention. Conventional X-ray are attenuated within the body and activate the film to emit light rays and image is produced. Computed radiography is CR. Its film receptor is replaced by reusable plates and could use old machines. Digital radiography is replaced by transistors. It is displayed on a monitor to be evaluated before patient leave them printed. No need for dark room or chemicals. No need for a space to store films. No need to change your old X-ray machine. The advantages of CR and DR: the better quality, changes could be made to image after the exposure, storage and digital archiving, so we can use PACS and teleradiology, less radiation dose, and also better infection control. Economic advantage, especially in the long run. DR is more expensive than CR, yet faster imaging viewer. Thus efficient for high workflow or mass chest examination and ICU. High resolution for special superficial structures and availability of duplex scanning. It's a real time, no radiation to patient or providers. Exam of contralateral side for comparison. These could be portable, relatively inexpensive, educational facilities to educate anatomy, technique, and interpretation. The advantage of X-ray of ultrasounds is limited field of view, limited penetration, operator dependent, which could be an advantage for some experts, cannot penetrate mature adult bone and air. CT, the advantage of CT is that it's a relatively quick imaging procedure, require minimal patient cooperation, excellent anatomical details. This advantage is exposure to patient to a large amount of ionizing radiation. There is a risk of contrast media, nephropathy, or allergic reaction. Evolution of CT scanning begin first by convolution CT. After each rotation, the gantry stop and rotate in the opposite direction. The limitation is slow scan time, poor ability to reformat images, no dynamic contrast studies. The small lesion could be missed. Spiral and thus multi-slice CT scanning. The ideal name is continuous data acquisition. We could alter slice thickness retrospectively without rescanning, reduce examination time. So in a single breath hold acquisition, no lesions could be missed, good control of delay between injection and scans, multiple phasic studies and efficient use of contrast media, longer scans, full organ coverage and trauma to scan trauma, whole body, and long vascular runoff. High resolution CT scanning is not the ideal scanning in many techniques, but only in diffuse interstitial lung disease, connective tissue disease, radiation-induced lung disease, diffuse metastatic disease. It's a thin cuts, high spatial resolution scanning. Indication of contrast injection in chest, pulmonary angiography, and perihilar and mediastinal lesions. Virtual bronchoscopy is a descriptive term given to representations of a bronchial tree and surrounding structures and 3D reform advantages. No irradiation, variable sequences, there's multiple planes, bone marrow imaging, characterized mediastinal injection. These advantages is long claustrophobic patients, so we need general anesthesia. Of course, less availability and high cost. Absolute contraindication of MR become less now. Cardiac pacemakers, electronic stimulators, aneurysm, eclipses, metallic foreign bodies. Now titanium plates are accepted in MRI. Nuclear medicine, scintigraphy. It's first planar isotope scanning, then single positron emission tomography or SPECT, positron emission tomography, PET, and others. SPECT provide true 3D reformatting. Positron emission tomography, the tracer emission positrons which combines the electrons to produce gamma rays detected by a scanner, then recorded by a computer program to reconstruct 3D images. The main tracer is FGG. The advantage could differentiate necrotic tissue, scar tissue, and inflammatory changes from malignants, and not differentiate based on anatomic, which are not differentiated based on anatomic imaging alone. Detect lymph nodes which are not pathologically enlarged by size criteria alone. High negative predictive value, so it excludes malignancy. The disadvantage is less spatial resolution, high percentage of false positive. PET limitations are the high cost and radiation dose. Diabetes may undergo a PET under certain circumstances and precautions. Hybrid imaging is the fusion of nuclear medicine with cross-sectional anatomic imaging to produce special views. Imaging-guided intervention, maybe CT-guided biopsy. It's a minimally invasive procedure, difficult in small lesions and risky in central and prevascular lesions. Complications as pulmonary hemorrhage and pneumothorax are frequent, but not severe. Pleural effusion, image-guided aspiration, laser and ablation of tumors, pulmonary artery intervention, whether diagnostic or therapeutic. In conclusion, ultrasound is better for superficial lesions, MRI for deep chest wall, mediastinal, and bone marrow lesions. CT is the best in pulmonary, vascular, and bone wall lesions. Nuclear medicine in bone marrow and metabolically active, tiny soft tissue lesions. Pediatric patients have a special character of radiation safety. Increasing number of radiation examinations are being performed in infants. Children are more radiosensitive than adults. They have longer life expectancy, high probability of developing cancer. We should use radiation protective principles to minimize probability of orthostatic effects. All pediatric examinations must be justified and optimized. Should be planned taking into account the size and age of the patients. Special needs for children can often be addressed by dedicated pediatric care centers or other centers with pediatric imaging expertise. Magnitude of the radiation used in pediatric imaging should be less than adults. The associated risk for equal exposure is greater due to the size, age, and radiosensitivity of pediatric organs As you see, the axial skeleton here in pediatrics is greater than for adults, so it is more sensitive to radiation. Literature for the hereditary effects, it is observed in offspring born after one or both parents had been exposed to radiation. Study on the sentence of Hiroshima and Nagasaki proves that there is no statistically significant increase in abnormalities after Hiroshima and Nagasaki insults. Clinical imaging guidelines are regulation for justification of investigations. Such projects have become vital for improving the quality. They were introduced in Medical Exposure Directive of 1997 as a legally binding requirement for EU member states. Health Insurance Hospital ensures that application of clinical referral guidelines should be done and no investigation done not following the CIG. Justification is a process in which a referring health provider and radiologist make a decision as whether the examination is clinically indicated and whether the benefit outweigh the radiation risks. When available, alternative techniques such as ultrasound and MRI will be used. And also pay attention to previous procedures and available information. Optimization or ALARA concept is as low as reasonable achievable, but not to the extent that affect the image quality. The aim of clinical imaging guidelines, the first aim is the best imaging for the patient for his practice and early diagnosis. Elimination of unnecessary imaging and radiation, optimizing the cost and service. It is available in booklets, online version, and app application. In England, 30% of all CT examinations were not justified. The challenges against implementation of clinical imaging guidelines are an awareness of physician and radiologist, congestion in clinics, patient pressure to perform the investigation as now in COVID, uneven distribution of machines, the fee splitting and self-referral. Fee splitting is the payment of commission to the referral with the expense that ensuring that his referring doctor directs referral of patient to the PE. The practice is illegal and unethical as it is conflict of interests. Self-referral is describing the practice of ordering tests on a patient that are performed by either referring physician himself or a fellow from whom he receives financial compensation in return of his referral. It is also illegal and unethical. The causes of inappropriate referral are doing the wrong investigation or not best imaging modality, failing to provide clinical data, repeating the examination, investigation which are too often, investigation which results are unlikely to affect patient management, improper or wrong preliminary diagnosis. The audit of appropriate imaging is the tables describing the causes of inappropriate referral. Examples, not the best imaging modality as superficial lesions, the best is ultrasound. Here is a referral asked for MRI study and with contrast. Also, emphysema, there is no need for contrast study. Too often as abuse request of chest X-ray in the neonatal ICU with portable machines. Investigation which results are unlikely to affect patient measurements as bronchial asthma. If there is no complications, plain X-ray will be normal. Improper or wrong in preliminary diagnosis, as is patient, there is a right lower zonal opacity. Physicians treat patients as a pneumonia, but after 3 months, CT scanning shows a tumor. So the primary diagnosis is wrong and should make CT scans from the start. The common patterns, there are 5 common patterns of lung disease: reticular pattern, ground glass pattern or veiling, consolidation pattern, nodular pattern, and cystic pattern. May be combined patterns as reticular and honeycombing and veiling and consolidation. Reticular pattern is innumerable small lines intersected with each other, making a net. Reticular pattern represent interstitial lung disease and may accompanied by honeycombing. Ground glass pattern or veiling is a partial alveolar filling. In X-ray, in our CT, it is a high density, not obscuring vascular marking. It is non-specific signs and see mainly in viral pneumonia, especially COVID-19. Consolidation pattern is a complete alveolar filling and obscuration of vascular structures. May be seen in pneumonia, neoplasm, or hemorrhage. Nodular pattern is a broad pattern of pulmonary opacification seen mainly in metastasis, miliary TB, miliary fungal infection, and sarcoidosis. Cystic pattern is a dilated air spaces. Main causes are emphysematous bully, bronchiectasis, breaking down, abscesses, pneumatocoel, and honeycombing. In pediatrics, there is many findings in X-ray, but we will interpret the common findings. Congenital pulmonary airway malformation is a dilated air spaces seen here in plain X-ray on the right side with deviation of the mediastinal and heart towards contralateral sides. That's CT scanning with dilated air spaces. Pulmonary sequestration. Here is in plain X-ray, the opacity, rounded opacity seen at the lower lung zone, left lower lung zone. CT scanning, soft tissue lesion here, or consolidation. That's angiography. The vessel is arising from the abdomen. The left inferior pulmonary vein is seen draining the sequestration. Diaphragmatic hernia, there are 2 types of diaphragmatic hernia. Ogdalic hernia, mainly on the left side, with shift of the heart and mediastinal structures towards the contralateral sides. Morgagni hernia is on the right side with displacement of the intestine upward within the thoracic cavity. Bronchogenic cyst is a opacity, well-defined opacity on the left side. Here in MRI, but it's not the same patient. There is a high signal on MRI signal representing cystic, well-defined, clear cystic lesion. Congenital lobar emphysema is dilated air spaces seen on the right lung. In X-ray, there is a hyperinflation of the right pulmonary of the right lung. Scimitar syndrome is a combination of pulmonary hypoplasia and partial anomalies pulmonary venous return. It is cyanotic, the patient is cyanotic, and due to left to right shunt. The anomalous vein usually drain into IVC, most commonly right atrium or portal vein. The lung is frequently perfused by the aorta, but the bronchial tree is still connected, and thus the lung is not perfused. That is high density of abnormal vein, like a scimitar. And here is angiography. Respiratory stress syndrome in the premature infants due to lack of surfactants. The initial features is low lung volume secondary to microcollapse, diffuse granule opacities, bilateral ground opacities due to collapsed alveoli. After surfactant administration, clearing of granular opacities and increase in lung volume. Pulmonary interstitial emphysema. There is diffuse pulmonary interstitial emphysema with multiple air lucences contiguous to pulmonary vessels and bronchi, with adjacent to pulmonary vessels and bronchi. Cystic fibrosis autosomal recessive disease of dilated bronchi in plain X-ray is a dilated air spaces, bilateral dilatation of air spaces. In CT scanning, coronal CT scanning, there is dilated air spaces of variable sizes. Mediastinal masses in pediatric mediastinal masses, lymphoma with encasement of vascular structures. Thymic hyperplasia, there is no convexity of the thymus. In thymoma, there is convexity and heterogeneity of the thymus. Picardial pad of fat is a almost normal variant, not to be interpreted as pneumonia or any mass lesions. That's CT scanning. It's a fat density lesion. Enteric foregut cyst. It's a cystic lesion also. Here in the background of the heart, and in CT scan is paravertebral lesion. Posterior mediastinal masses is a common in pediatrics. In first decades, it's usually malignant, and second decades, it's usually benign. As CT scanning, there is a malignant lesion, neuroblastoma. Clinical imaging guidelines begins in acute chest infection by chest X-ray and then CT scanning in special considerations. That's plain X-ray. The lesion is not defined in plain X-ray, and in CT scanning coronal cuts due to better resolution, the ground glass opacity is seen here. Bacterial pulmonary infection characterized by segmental or lobar pneumonia. Here is a segment. Here and here is a consolidation, bilateral consolidation, may be accompanied by pleural effusion. TB, primary TB may be also a consolidation patch. Then in miliary TB, it is a nodular lesions, bilateral nodular lesion. Here is plain X-ray, and here in CT scanning. Viral pulmonary infection characterized by peribronchial patchy consolidation, and here in CT scanning, also peribronchial patchy consolidation or ground glass appearance. COVID-19 is characterized by peripheral ground glass opacity. In pediatrics, is similar to those seen in adults, but CT finds are fewer and to a lesser extent. It is also peribronchial and associated with bronchial wall thickening with less strands and septal thickening. Also, it may be crazy paving pattern, strands within the consolidation, sometimes vascular dilatation, traction, bronchitis, and subpleural bends. CT reports in COVID should write CT findings, the CORADS and CT severity score, CORADS classification. There is many literature about assessment of severity or involvement score, distributing the lung into 12 segments or 20 segments. That's the distribution of lung affection in COVID. X-ray is better in follow-up than CT scanning due to less radiation. That's a male patient with positive PCR, first medication from 2 April to 13 April with positive PCR. Bilateral patchy ground glass opacities is seen, namely peripheral and lower lobar, and to a lesser extent at right upper lobe. It is classic COVID cohort 6. Sometimes COVID presentation in the lung will be tiny peripheral ground glass opacity as seen here, but it is a classic COVID. That's also patients with typical CT findings of COVID, bilateral ground glass opacities, namely peripheral, intermingled with some strands and septal thickening. Lastly, teleradiology now in COVID-19 pandemic is more beneficial in areas deficient in radiology specialists or subspecialists, has gone global driven by the explosion in night call coverage and a concomitant slump in the radiology workforce. The idea of sending imaging around the world has taken as a new twist. Radiologists are seeing the potential to exploit global time differences as a way to turn a night duty into day. We could write reports in Cairo or India, which are done in night shift in USA hospitals. Lately, in COVID-19 pandemic, teleradiology is a good tool to guard against transmission of infection. Lastly, radiology is a double-edged sword. Mistakes lead to false or delayed diagnosis, thus improper treatments, increased morbidity and mortality, consumables abuse, and radiation exposure. Referring physician should provide clinical data, previous exams, and be aware by imaging modalities and ethical concern, and should communicate with radiologists. Radiologist's choice of best imaging modality, manage technique, communication with patient and referring position, and careful interpretation and proper reporting. That's some useful websites and my personal email. Thank you. We'll shift to some ask and we'll answer this question within 5 minutes.